Thanks for being here today. It's my pleasure to introduce the annual Julia Berg Memorial Lecture, and as a matter of introduction, I'd like to tell you a little bit about Julia. Julia Berg was a complex, courageous, smart, and challenging young woman. She was going to be a sophomore in the International Baccalaureate program at Southwest High School here in Minneapolis in the fall of 2005. Julia loved her friends, movies, roller coasters, and world travel. She loved the music of Modest Mouse, the Flaming Lips, Coldplay, and the Beatles. She was a swimmer, an actor in the summer theater program E3, and a budding social activist. Her passions were social justice, GLBT issues, and the environment. And she'd recently completed an internship with the local Sierra Club doing grassroots organizing and issue research. She spoke of taking her activism to new levels in the year ahead. Julia died in August that summer in 2005. She was hospitalized for a presumed gallbladder infection, and 6 days later she was gone. Those who treated Julia and those who have reviewed her death agree on at least one thing, and that is that the system let her down. Julia's parents, Welcome Jurdy and Dan Berg, created the Julia Berg Memorial Lecture Fund at the Minnesota Medical Foundation as one way to keep the issue of patient safety, especially for children, in the forefront of medical education. Welcome and Dan are here today, and I ask you to join me in thanking them for their generous gift in support of medical education and patient safety. Welcome and Dan. I'm honored to introduce our speaker for today's Berg Lecture, and that's Jim Conway. Jim is an adjunct lecturer at the Harvard School of Public Health in Boston and principal of the Governance and Leadership Group of Pascal Metrics in Washington, D.C. He's a senior fellow at the Institute for Healthcare Improvement in Cambridge. He was senior president of IHI from 2006 to 2009 and senior fellow from 2005 to 2006. From 1995 to 2005, Jim was executive vice president and CEO of the Dana-Farber Cancer Institute in Boston. Prior to joining Dana-Farber, he was at Children's Hospital in Boston for 27 years in radiology, administration, and finance, and as assistant hospital director. His areas of expertise and interest include governance and executive leadership, patient safety, change management, and patient and family-centered care. He holds a Master's of Science degree from Lesley College, which awarded him the Community Service Award. Jim's the winner of numerous awards, including the 1999 ACHE Massachusetts Regents Award. In 2001, he received the first Individual Leadership Award in patient safety from the Joint Commission on Accreditation of Healthcare Organizations and the National Committee for Quality Assurance in 2008. He received the Picker Award for Excellence in the Advancement of Patient-Centered Care, and in 2009, the Mary Davis Barber Heart of Hospice Award from the Massachusetts Hospice and Palliative Care Federation. A fellow of the American College of Healthcare Executives, Jim is a member of the Clinical Issues Advisory Council of the Massachusetts Hospital Association and is a distinguished advisor to the Lucian Leap Institute for the National Patient Safety Foundation. He's board chair of the Partnership for Healthcare Excellence, a board member of Winchester Hospital and the American Cancer Society, New England Region, and a board advisor to medically induced trauma support services. In government service, he served from 2006 to 2010 as a member of the Commonwealth of Massachusetts Quality and Cost Council. Those credentials are impressive, but when I met Jim, I knew he was a man of integrity because of the striking resemblance he bears to Farmer Hoggett in the movie Babe, and I think you'll see that when he stands up. So without further ado, I'd like to welcome Jim Conway to give the 2012 Julia Berg Lecture. Jim?
Thank you. So excuse me while I go to the web to find out who this farmer is. I've watched Babe. It's a real privilege to be in your presence today. When somebody reads the long background of my accomplishments, I always in the distance hear my wife screaming, "That's nice, but are you going to be home tonight?" It's a thrill to jump into this, not only this lecture, but the privilege of spending part of the morning with a number of the staff of the University of Minnesota, and we'll talk about that a little bit later. As I jump into my presentation, please note my email address. It's there for you. The state of Minnesota, the people of Fairview, and the neighboring institutions have given me so much in my career. if there's anything that I can do to give back, I want to. We're going to talk about lots of stuff. We're going to talk about lots of studies. I have one of the world's all-time collections of PDF files. So as long as you don't tell Harvard that I denied them the $3 that they could have gotten if you bought this online, I would be happy to give you that work. Let's welcome Julia in the room, and with that, Dan, and welcome. It is just, and it has been remarkable for me to read about her. I've read the whole website. We had an amazing dinner last evening with family and friends, talking about Julia, her passion, and what she sought to achieve. And everything about this presentation is dedicated to her and all she had given us and will continue to give us. For the CME police, here's my disclosures. None of them lead to big money, but that's what you have. The learning objectives here also for the CME people. The first is I want to start out just bringing us into the space of the magnitude of medical errors. Paul Sharrock did that last year. I want to do that again for reasons I'll explain in my talk. Second, I want to focus on the crucial role that leadership, culture, systems, and patient and family-centered care play in supporting safe practice. And the third is I want to demonstrate the power a respectfully and effectively handled medical error can have in stimulating resolution, healing, learning, and improvement. So my title is The Burden. When patients suffer under our watch, we carry the burden for those patients forever, and we should. But carrying the burden is not enough. We have a responsibility to learn everything we can to prevent such events from happening again. And then what I've learned as a leader is we have this gift, a weird gift, a strange gift, but a remarkable gift if we have the courage to do it, to use great tragedy to take our organizations and our practice to a very different place. And we'll talk about that. The outline for the presentation is the immense proportions. We're going to talk about, this isn't abstract. This isn't even just about Julia. This is personal. This is personal in all of our lives. We'll talk about the burden, responsibility, and power. Then we're going to talk about something I call respectful management of serious adverse events. I want to, as we bring this to close, I want to let you know what a guy who gets around is seeing. And I'm a hospital trustee. I teach physicians at the Harvard School of Public Health. I have visited all 50 states. I've traveled extensively in Europe, all around Canada. And I have some growing worries, and I want to share those with you and then end with the path forward. So the first thing I want to do is to congratulate you for your practice. As one of the early leaders in patient safety in the country, a city I constantly looked to was Minneapolis and St. Paul. A system I looked to was Fairview. An environment I looked to was the university environment. I don't know if you know that some of the great work in medication safety in the country grew out of Steve Meisel and the crowd in this particular community. So the first is I want to thank you as a community for all you've given. The second is I just want to congratulate you on your practice. So this morning I went to the opening meeting where a case was reviewed. And what I was struck with was the way that everybody treated everybody else respectfully in the didactic discussion that was going on. I'm an operations guy. I can see when that's not natural in about a microsecond. And I was struck about that. I was also struck as I did rounds today with one of the teams upstairs, again at this very respectful engagement. I was struck clearly by the beauty of your physical plant, but I've learned a long time ago that at first is the people, then it's the physical plant. And I was struck with the whiteboards in the rooms. I was struck with the attention that was going on to update those whiteboards. The most important value that I've seen in my career is the value of respect. And I want to congratulate you because in my observations of the last 6 hours, I've observed respectful practice everywhere I went. Well, let's move into this presentation and one of the slides from Paul Sharrock's deck of last year. Paul told you that we have 203 adverse events per 100 admissions. So nationally, the IOM estimated that if you're admitted to an American hospital today, you can expect to have one preventable adverse drug event for every day you're in the hospital. If you get to go to the ICU or interventive radiology or any place else, that number goes up exponentially. So that's the prevalence. It's a scary number. Then if you carry the Medicare card, there's an increasingly scary number. Back in November of 2010, Medicare in the Office of the Inspector General determined that 6,600 preventable Medicare deaths occur monthly. Monthly. For many of you in your room, that could be your mothers and fathers. It could be your grandparents. It could be me. That we have this extraordinary burden of harm. Then we have Mark Chasson, the president of the Joint Commission, writing last April that Mark is concerned that it's getting worse instead of it getting better. Then we've had this range of studies that have come out in 2011 and 2012 that have said in the aggregate, we are not able to see improvement in safety. Are there organizations doing spectacular work? You better believe it. I am inspired by them every day. Are there organizations I meet that don't have a clue? You better believe it. But for all the energy that has gone into this movement since 1999 with the release of To Err is Human, to say that we have nothing in the aggregate to show for it is unbelievably hard. And then back in your world, the team at Children's in Cincinnati a few weeks ago released this paper. Using the IHI Global Trigger Tool, they demonstrated its use in a pediatric setting, their institution. With the use of the trigger tool, we identified a rate of harm 2 to 3 times higher than previously published in pediatric rates. So just in the period since Paul's lecture and this today, there is now a study that says, as bad as it looked last year, it looks like the toll is 2 to 3 times what it used to be. So that is confronting the realities of practice. So I want to take you on a journey with me to go back into a few milestones in my learning around patient safety. So in 1966, I was studying to be a high school science teacher at Boston State College. I was broke. I needed some money for Christmas. And I took a 30-day job at Children's Hospital in Boston filing x-rays. That began my 47-year career in healthcare. In 1970s at Children's, mothers, periodically a father, but honestly, guys, it was mothers, began to drive accommodation in the state education system for children with special needs. And they were unbelievably successful. And then they turned their eyes on health care. And they said to me as an administrator on duty on call, I don't care who you are, I'm not going home. I don't care who you are, I'm going to be in the x-ray room with my kid, I'm going to be in the unit with my kid. And I discovered a few things. The first is there's no force in the world stronger than a mother in your face advocating for her kid. I learned that, something you all know. The second is I learned the power and privilege of partnerships with patients, with children, teenagers, and adults. I also, during that period of time, had a mother say to me, you know, Jim, just because you're poor doesn't mean you're stupid. And that began my journey in unleashing as a leader the privilege of patient and family-centered care. In 1980, I was working at radiology at Children's. I was the department administrator, and I took an emergency phone call from my sister, who said, Jim, you better come home. I think Dad's dead. I went home. My father had gone to the emergency room of the hospital my sister worked in. They knew exactly what was wrong with him, even when he said, that doesn't make sense. But they knew exactly what was wrong. The ED was busy that day. It wasn't bad people. It was crazy in the ED. So without a cardiogram, without lab work, without even a stethoscope up to his chest, they wrote a script and sent him home. And when he took the muscle relaxer on top of the heart attack he had, it killed him in his chair. What was extraordinary in my journey, because my father was a retired cop, and because my sister and I had privileged access, we were able to influence the system in 1980, and we'll talk about that again in the end. In 1995, I left Children's. It had been a spectacular journey. I had heard that there was health care out of the Harvard medical area. I thought I'd check. But I was very frustrated. Children's in Boston is an exceptional organization with extraordinary resources, aka lots of money. But despite all of that money and despite all of the talent, getting anything changed at Children's was cold day in hell. It just was unbelievably hard. So after I left Children's, I went to MIT to take a course in managing change in complex organizations. It was a 2-week program taught by people by the name of Edgar Schein and Peter Senge and Lolly Bayliss and a whole bunch of other people. And I learned the most important concept I've learned in my career. So this is a Harvard academic who was saying, this is the most important concept. And what Peter Senge taught me is this notion of creative tension. Peter said leadership in a learning organization starts with the principle of creative tension. So creative tension clearly comes from seeing what you want to be, your vision, but then confronting the reality of where you are. Because many of us have these sweeping visions, but do we really, that's just blue sky and bold, unless you map your vision against the reality. I didn't know at that time the impact of that, but I was going to find it very quickly. Shortly after that course, I was invited to join the Dana-Farber Cancer Institute after Dana-Farber killed Betsy Lehman, Betsy was the wife of one of Dana-Farber's cancer researchers, and she was the lead Boston Globe reporter on health. Saul Weingart, when he was here, introduced you to Betsy. And the Dana-Farber Board of Trustees believed that they had a moral and ethical responsibility to disclose. When frankly, in 1995, people didn't disclose. They would typically say, the family's been through a lot. There's not a lot to be gained. We'd fire a few staff, we'd rewrite a policy, and we would hope it would never happen again. But the Board of Trustees said that we had this moral and ethical responsibility, knowing that the Boston Globe would find out as soon as we told Bob that we had killed his wife. And people talk to me about my use of the word kill. I do it very intentionally. If I talk about serious adverse event, if I talk about untoward event, if I talk about nosocomial anything, it doesn't create outrage. If I talk about kill, it does. Besides, that's what Betsy's family said we did. And then Dana-Farber began the journey to move forward, and in the process discovered this notion, the arrogance of excellence, something that we're at risk of, something that you as an organization are at risk of. The notion of the arrogance of excellence came out of the first shuttle disaster by NASA. And you know, as people probed that, when we met with Diane Vaughan and the group at Boston College after this, NASA had so many good stories that just like us, they could spend every moment of every day talking about the good stuff. The care, the caring, the hope, the discovery, and not create a space to talk about the suffering, the harm, the tragedy, the death that occurs in our organization. So when the Joint Commission and NIH and CMS and the Department of Public Health all descended on Dana-Farber and found stuff, none of that stuff they found was a surprise to the people who delivered care, because it was the world that you live in every day. But for the people who ran the place, it was all news, because we had not created the opportunity to confront the realities of practice. And then I thought instantly about what Peter Senge taught me. Dana-Farber's vision was to cure cancer and relieve the burden of cancer on those who had it. Our realities was we killed the wife of one of our staff. And then we discovered this unbelievably fueled resource to drive the organization. So we set a goal that in 2 to 3 years we would be recognized as a leader nationally in the area of safety in cancer care. Until we set that goal, the organization was carrying around the burden and the responsibility, but when we unleashed this possibility, everybody got unbelievably behind it. So what did we learn? The first thing is the exquisite responsibility of leadership to lead. This is the responsibility of governing boards and executive leadership. We learned the need for the relentless vigilance to safety, risk, error. We work in a high-risk industry. We are much higher risk than bungee jumping. The risks associated with coming into healthcare every day for an inpatient admission are higher than that. We also learned that we had to address the multiple victims of error, the patients and family members, also the frontline staff, who the last thing you expected to do today when you came to work was to hurt somebody, to make a mistake. We had to support that. We learned the crucial role that systems play, and I'll talk about that. We learned about the synergy of interdisciplinary practice and teamwork. So when I entered Dana-Farber, we had virtuoso nurses, virtuoso pharmacists, virtuoso physicians. We had no conductor, we had no score. So What I was looking for this morning in your rounds is I was looking for the nurse and the pharmacist and the house staff and the medical student and the physician to be engaged in respectful processes that celebrated the role of interdisciplinary practice. And then we learned the extraordinary power of patient and family-centered care. So this is one of my mantras that came out of the Dana-Farber. I, honest to God, thought they were sick of it because I had said it 1,000 times. And when I was leaving the Dana-Farber, the nursing department engraved part of this on a chair they gave me. And the mantra is, our systems are too complex to expect merely extraordinary people, like each of you, to perform perfectly 100% of the time. We as leaders must put in place systems that support your safe practice. No matter how good you are, no matter how many degrees you have, no matter how committed you are, you suffer from being human. You are going to make mistakes. We as leadership have a responsibility to put in place systems below you that mitigate the chances of your humanness to get to a patient and cause harm. When asked who killed Betsy Lehman, it was the governing board and the executive leadership who expected people, physicians, nurses, and pharmacists, to act perfectly 100% of the time and did not put under you the systems that support safe practice. We learned so much about the concepts of patient and family-centered care. When I left the Children's, everything we did was in partnership. We had a parent advisory council for 15 years. Everything we did was in partnership with the patient, the family. And when I got to adult care, I couldn't find the patient. I said, so where do you sit down? So we, in 1966, by board vote, by 1996, invited patients and families to populate all decision-making bodies and structures of Dana-Farber. If it was about care, we could not meet without having the patient and family. So I'm not going to go through this, but let me explain the picture of the room. They asked for all kinds of things. Then they wanted an office on the first floor of the hospital. That was sort of like, any of you know who have to deal with space, that was like the hardest thing, but they got their office. Starting with the governing board, since 1996 at Dana-Farber, four patients and families have populated all governing board conversations around quality and safety of the organization. You could not have any strategic planning meeting. You could not renovate a facility without having patients and families as part of the design team. And on and on. And the gifts they gave us were exceptional because the only people who really understand the care we give are the patients and families. We think we know how it works. And even if we know in our silo, we don't know if you can get from A to B to C. But the patient and family does. In 2000, on the 10th anniversary of the Lehman overdose, ASCO asked the American Society of Clinical Oncology asked us to the leadership of Dana-Farber to write what we learned. And they asked us to reflect on this notion of a culture of safety. And we did that, and I want to point you to this first bullet. It's a culture that's based in trust, respect, human rights, repentance, and forgiveness. What we learned is you couldn't establish a culture of safety if you treated people like crap everywhere else, if you were disrespectful anywhere else, if you tolerated abusive behavior anywhere else. So for Dana-Farber, that became a huge part of our issue because we, in our mission to cure cancer, ran over people on the way, and we had to go after this notion of respect. So this morning, as the operations guy is watching your practice here, I was evaluating whether or not I was seeing respectful practice, because I know there's all of these other things are part of the culture, but it's anchored in respect. And we wrote the article for ASCO. This hyperlink will take you to the article where we introduced this notion of the burden. We carried the burden of Betsy's death, and we should forever. But carrying the burden wasn't enough. We had a responsibility to assure that we never killed another patient under our watch. And we actually thought it ended there, and then we discovered the enormous potential in the creative tension. We had doctors and nurses and pharmacists and clerks all petrified that something about their practice could hurt a patient. And all of them wanted to know how they could get on this journey with us. And out of that came things like Dana-Farber Children's Cancer Center, Dana-Farber Partners Cancer Center, Dana-Farber Harvard Cancer Center grant, because we discovered, we stood back, we assessed, and discovered the extraordinary potential of collaborative practice. Unfortunately, we've talked today about Julia, and we've talked about my father, and we've talked about Betsy Lehman, but it's not just them. All of these people up here are people who are I know all of their stories. I know all about them. It's about lots of people and tens of thousands more who suffer great tragedy. One of the interesting burdens, and it's both been a burden and a privilege, is since 1995, I've taken hundreds of phone calls. It typically is from a CEO. It says, Jim, sorry to disturb you. We just had a terrible error in the ICU. The patient's dead. What should we do? What I've been struck with these calls is the absolute devastation of the person calling. None of us go into this business to hurt somebody. I've been struck by the similarities of the story. No matter what you tell me that now, I've heard the story before. I am struck that people are working from a blank sheet of paper. They're winging it. The response is highly reactive. It's quite unbalanced, always worrying about the best interest of the organization, increasingly worrying about the patient and family, and still forgetting to support the frontline staff. And also struck that they're underestimating the potential harm to all. So I engaged in a process with IHI and 85 collaborators. Never do anything with 85 collaborators, or have access to drugs and booze if you do. But and we basically determined in the aftermath of tragedy, our goal is to eliminate the chances of these errors happening. But until we do, when they happen, for the patient and family, for the staff, for the organization, there's very specific steps we have to go through. The first is the step of empathy. I'm sorry. You know, about 10 years ago, I was in the Longwood medical area, and I walked by a woman sitting on the curb. And she was all by herself, and she was very well dressed, and she was weeping, and I sat beside her, and I asked her what the matter was. And she told me a family member had just died in the hospital besides where we were sitting. And I just wondered how in God's name anybody let her out. You know, how did we develop the system of empathy around what had happened? What we've learned, and that empathy also has to be for the staff. You know, who went to the unit? There's a wonderful, out of the Minneapolis law, there's an amazing story of Gordy Springer. In the 90s, when an event happened in one of the affiliated hospitals, calling the hospital and expressing his support for the staff and the fact that they would work with them together to figure it out. There has to be empathy, then there has to be disclosure. Then there needs to be support. Sometimes that's money. Not big money, it's just a hotel room. Then there needs to be a careful assessment. Then based on what you found out, there needs to be apology. Then there needs to be resolution, learning, and improvement. What I am seeing nationally is we're doing a better job on the apology, but we're losing the cases in resolution, learning, and improvement because claims people are getting involved with them, and the same leadership team and the clinical team isn't staying involved. So what we did, the goal in this work, was to have all organizations develop a crisis plan so they would know before they have to deal with the event. But what we've developed is a checklist that any organization can access, that when you have one of the events, what are the steps that you need to do. I was very pleased that when I went on the website, I read the following paragraph. In 2007, we settled a wrongful death suit that we had brought against the hospital and the doctors. It was a painful process for us, but we felt that we needed an independent assessment of what happened, and the legal system provides for this. At every turn in this protracted process, we encountered nothing but respect and compassion. That led to the development of this white paper that's now been accessed over 80,000 times. This hyperlink will take you into a whole bunch of resources. I want to go from that to another example. I'm a trustee of Winchester Hospital, Winchester, Mass., and I want to talk about an example from our work that addressed this notion of the burden, the responsibility, the power. It's based in a notion of something we've learned in our board work, that nothing builds will more than meeting the patient, the family, the public. It's why I showed Julia's picture today. It's why it's so wonderful to have you here. Nothing builds will for more than meeting the patient, the family, the public. So in 2008, I wasn't on the board at Winchester. I was at IHI. Winchester went to a course. The whole leadership went to something called IHI's Executive Quality Academy, and they realized for all of the good work they were doing, they were absolutely missing the mark in the area of quality and safety. So they went back to the organization and said, okay, let's pick 5 areas of harm that we have understanding of what the measures are and see how we're doing. So these are the areas we went after. In adult practice, very typical areas: falls with injuries, VAPs, serious med errors, surgical site infections, and central line infections. We were shocked to find out in 2008 to 2009, we had 108 of those. So we set a goal to reduce it by 50%. There's our goal. Now I want to show you what happened at every board meeting for the year. We would meet the people we harmed in a community hospital. In total silence, their names would scroll across the screen, and the trustees, the executive leadership, the clinical leadership would sit there and meet the patients. So there was absolutely no confusion around the urgency, the anger, the frustration. We're a community hospital. We know these people. We work with these people. And this one, Kelly, 1 year old, the room gulps as every time Kelly would go by. Then you meet the others, and then we celebrated having no central line bloodstream infections. So we put together a very rigorous program of how we were going to drive this number down. And in actuality, that year we had 38 events. So we beat our goal. Then we said our goal in 2010 was going to be 27. Our goal in 2011 was 0. Well, look what happened. We went from 108 to 38 to 4 on audit. Because we all know that people will play to the numbers, not because they're bad, but it's a fact of life. And this sign is in every public space at my hospital. So if you walk into the lobby, you will see the current version of this sign. If you go to every patient care unit. And what we found out is people carried the burden, but they were blown away by their collected capability to go from 108 to 4. Look what we can do. So then they got out of control, and they decided to call certain categories of readmission preventable harm. Whoa. But they are, they told us. I was just at a board meeting this week. So when I get my board book at the house, this is the front page. When I walk into the board meeting at Winchester Hospital, as I did on Tuesday, on the screen as I walked in was this slide. It's the focus, it's confronting the harm, but it's realizing not only is it had, but it unleashes remarkable potential. This is the biweekly newsletter that goes out. So this paragraph, thus far in fiscal 2012, there have been 26 preventable harm events. We tell everybody and anybody. Some of you know Children's Hospital Cincinnati on their website, if you're an employee of Children's. When you dial onto their intranet, you can see the number of days that have gone by since an employee's been hurt in the job. You can read what the incident was, and you can see the number of days that have gone by since a child was last seriously harmed at Children's, and you can see the number of days that have gone by. That's back to Sanghi. We have these glorious missions, but are we always confronting of where we are against that mission? So let me just quickly run through some worries. The first is the waterfall. I was interviewing a nurse in Albuquerque, and I asked her what she loved about her practice and then what got in the way of her delivering the care she wanted to deliver. And she said to me, Jim, every day I walk into work, I'm sitting at the bottom of a waterfall, and the stuff just keeps come and come and come. And when I'm traveling the country, I am finding rooms full of people sitting on the bottom of waterfalls, just drowning in the number of interventions, which is an abysmal failure of leadership to focus, to prioritize, to align, to make sense of. The second is confronting the reality that most change fails. Your brilliant ideas, your change initiatives, the likelihood of that failing is 70 to 80%. Why? First major reason is the failure to engage the people closest to the work. And you know what that all looks like. We all do it. This too shall pass. He'll be gone before I have to deal with this. The second is failure of leaders to follow the behaviors necessary to sustain the change. It's something I call leadership attention deficit, where we ask you to lead an initiative, but then we're not there to provide support. Another thing I'm very concerned coming out of academic work in Japan is something called the Iceberg of Ignorance. If we take the 100% of crap which is known by people close to the work, only 4% of that is known by senior management. So senior management is developing all of these elegant org charts and Visios and everything, And here you are on 6 West in utter chaos, wondering how in God's name you're going to get through the shift. The view of the organization is very different based on where you sit. And leadership struggles in its vision. At a time when everybody's talking about coordination and collaboration, I'm watching people developing very elegant silos out there. They're not touching my money. They're not touching my revenue stream. No way in hell we're going over there. I love this elegant silo. Not probably Midwest. I worry that ARC continues, the Agency for Healthcare Research and Quality, continues to find that 56% of you will say that if you reported an adverse event, you'd be treated punitively. I've been very concerned about culture. Crappy cultures produce crappy results. High-performance teams can accomplish anything. Now we have all of this growing literature that says if you can't stand each other's guts, if you're not working together as a team, if you're not treating each other respectfully, then all of these things will happen. Right before I left Dana-Farber, we were having a presentation on IT systems, and I was raising some questions about doing a critical risk analysis to find out what new categories of error we were introducing, and a very senior physician said to me, "Aren't you ever satisfied?" And I said, "No." Because some people from Ann Arbor, Carl White and Kathleen Sutcliffe, told me that if I want to develop a high reliable organization, I have to have a preoccupation with failure. I have to confront the arrogance of excellence. I have to confront the space that exists between all of the wonderful things we do. As I bring this to a close, I just want to point you to a recent IOM report that was released back in September. It's called Best Care at Lower Cost. And they provide for all of us what this path needs to be. The first is real-time knowledge through IT systems that don't just meet meaningful use criteria, but support our practice in ways that complements practice, not only gets in the way. We have to engage patients and families at every level. We have to align incentives across the organization. We have to create a new culture of care. The IOM report is very clear about cultures. We're becoming very concerned about cultures that tolerate extraordinary variance and highly disrespectful behavior. And we have to integrate stakeholders across the community. It can't be the work of the elegant silo. I love the vision of the chart that in the center is the patient, the community, and the clinician, and the realization that until we organize the healthcare system around the people we're privileged to serve, we're not going to figure any of this out. And in this ring here, which is difficult to read, are leadership, incentives, and culture. So let's go back to the beginning. When my father died, my mother wanted to know, "Jim, I don't want to sue. I just want to know what happened, why, and what's being done to have that happen again." In my family, we saw the burden of my father's death. My mother had a very hard life after my father's death. If she had sued, she could have gotten money for it, but she didn't want to go there. It's understanding the burden. The organization accepted the responsibility and achieved the power, much like we're seeing in this lecture series endowed by the Bergs, that allows Julia's experience to go forward. So we have a few minutes, about 6 or 7 minutes for Q&A, so let me, with Julia joining us, open it up for questions, comments, reactions. Yes, sir.
First of all, thanks very much for a terrific talk. I wanted to ask you to comment, if you would, about resident work hours. Ever since the Libby Zion case, and for the last 25 years, there's been this evolution in resident work hour requirements, I think largely driven by the hope that we would reduce some of these errors. Is there any actual data that we have, and what are your comments and perspectives on that from a House officer perspective?
So the IOM has looked at this. Maureen Bizignano, who's currently the CEO of IHI, has looked at it. Coming out of Europe largely, there is evidence, that this has had a very material impact. The problem that I saw what happened in the States is we reduced the resident work hours, but we didn't do the business process redesign that was necessary to have care be delivered safely while we had all of this transitions going on. So I was pleased to meet in your organization hospitalists. I know within a cancer institution, we've had hospitalists join, and for a lot of reasons, but one is to facilitate the transitions when we had so much going on. I think we have a lot more work to do around the business process redesign. I was talking to the medical students and the residents, and I asked them sort of what they worry about, and this is a topic that they worry about. It's the handoffs, it's the information. Did they remember to, they worry they forgot to tell the handoff something. And so I think, again, we have to be very careful about the mantra, our systems are too complex to expect merely extraordinary people. I think we have more work to do there. I do believe from the trucking industries, from a lot of other industries, we know from the work that's been done in pediatrics out of Children's in Boston and others, that people who work long hours aren't as good in a lot of their cognitive abilities. So we have to be aware of that, but we have to do not just plug and play, but do the business process redesign. Yeah, other comments, reactions, questions, comments? I'm a Harvard faculty member, so I also know how to just know you were going to volunteer, so I'll ask you. So they have to, yeah, please, thank you.
So, Dr. Elliott, I mentioned that the electronic medical record is one of my areas that I deal with here. You mentioned that you talked about new areas of error that may be created to that. What were some of the things that came forward when you had that discussion?
Well, the first thing is I love Betsy Lehman could not be killed at Dana-Farber because the electronic health record and the chemo order entry system would have stopped that order from going through. It was a fourfold overdose of chemo. I think on the plus side, let's go to the dark side. The big thing is alert overload. There's so many alerts that people aren't looking at them. It's just hitting escape, and there's a notion that they teach you in human factors work called the normalization of deviance. You come into work and you got to get through this day, and if you have all this crap, then you just jump the hurdles. It's the way you get through. You got to get over this. So if you have all of these alerts, I don't think we're prioritizing. I learned as a leader after the Lehman overdose that if you try to do everything, you'll accomplish nothing. And I think we know there's lots of alerts, but some are much more important than others. And what we really have to do a better job at is prioritizing that. The other thing, and I understand it's something that you struggle with, is the silos. So the hospital has their IT system. The medical group has the IT system. The community hospital that you work with has their system, and never the twain will meet. And that is now creating, we used to joke that Dana-Farber and Harvard Pilgrim Health Plan were two great hospitals with great IT systems that were connected by a prescription blank. That we have not worried about integration in the degree that we had to, but the big challenge right now in safety is the alert overload. And the other thing that we talked about earlier today is the lack of standard work. I know you all want to have it done your way to meet exactly your templates and everything, but if the Mass General, the Brigham, and the Dana-Farber can develop a single chemo order entry system to support cancer care, anybody can do it. I can tell you because there were lives lost over that. We have to approach the notion of standard work. Winging it Doing it whatever way you want does not meet any of the requirements of high reliability organizations, so we can't let that go forward. We can't let that go forward. So this current interest in customization is going to kill us realizing a lot of the potential of these systems that we have. And we have time for one more question or observation, if anybody has. Yes, sir. Thank you.
I'm curious, as a resident now, who's actually there's on the medicine side of things, I actually just started a chief residency in quality improvement specifically. So in 2 years, I'm going to be doing that position. And one of the things
Congratulations. That's great.
But I think one of the things that comes up often is how do you really inculcate and train residents in those future positions and to say, how do you think patient safety? And I still struggle with, what does that really mean, and how do you really do these systems-based projects where you maybe think of one thing in a month, but then you walk away and you never see it again?
Yeah.
How do you really start that process?
Well, when Ed Benz came to Dana-Farber from Johns Hopkins to be the CEO, Ed told me that safety didn't have academic legitimacy. So we first had to give it academic legitimacy in the same way we do others, and that's what the roles that existed, the financial support. I was telling him last night at dinner that we gave Saul Weingarten an amazing dowry to attract him to come to Dana-Farber, but then we also had certain assurances that were provided at the leadership level. So the one thing that's very clear is you need to, between now and then, understand what your cover is, the cover that you're going to get from the governing board and the executive leadership, also the department chairs, that this isn't just somebody in the congregation of second bananas doing quality and safety. This is a leading academic initiative of the institution. The second, you have to meet people like you. So I would encourage you to connect with Saul. Saul's associate professor, moving to full professor at Dana-Farber, very strong academic career in Harvard coming out of there. Paul Sharrock, others. Meet people, and then it's then embedding this. So if you look at the work that Ken Sands has done in the BI Deaconess, every house officer at the BI Deaconess has to do a project in quality and safety, and every one of them has to be real work. It can't be make-up project. It has to be real work addressing an institutional dilemma, challenge. So when I recently was a guest at the board quality committee of the BI Deaconess, house staff were in the room, because they are an integral component. If we just put it in a separate silo and we put a bow around it, it's not going to we're not going to make it the way we do the work. If you fully embed it in the decision-making bodies and structures, fulfilling the institutional priorities and processes, then you will have, then it will get lived. And Ken Sands, I think they, of any organization, have some of the longest experience with house staff in this space. And I see the bewitching hour is here. I'll stay up at the end, but thank you.